following program on Ada Derana 24 is classified for general audience. It is intended for all ages. It contains little or no violence, no strong language, and little or no sexual dialogue or situations.
Very good evening to everyone watching tonight. You are joining us on a special report here on Ada Derana 24. Tonight we're going to be talking about a subject that I'm sure a lot of us have heard of, but I'm pretty sure that not many of us know the exact details or even sometimes the hotlines that we have to contact, and that's about trauma care in Sri Lanka. Now, when it comes to trauma, a lot of us would associate it with mental trauma these days because we don't really see that many physical accidents. But trauma care is something that is integral to every health system in every country, and we have to address key issues and key developments in this field in Sri Lanka. And to do that, I have with us two very special guests. First, on my right, we have Professor Raj Menon of the Trauma and Vascular Surgeon of Head Trauma Service in the National University Hospital of Singapore. He's also the Vice Chairman of the Asian Collaboration for Trauma. Doctor, thank you very much for taking the time to speak to us today.
Thank you very much for having me.
And on my left, we have with us a local hero, I believe, when it comes to the efforts that have been taken for trauma care in Sri Lanka, and that is Dr. Kamal Jayasuriya, who is the Director for National Trauma Management Course, the National Delegate for the ISS, and of course, the Asian Collaboration for Trauma. He is an Executive Committee member of that as well, a Sri Lanka representative. Thank you very much, Doctor, for taking the time to speak to us today.
Thank you for inviting for this session.
All right, well, we have quite a lot to break down tonight as well, especially because this is such a very wide-ranging topic, and there's a lot that the general public might not understand about the current status, the current environment that is in trauma care in Sri Lanka. So how about we start off with you, Dr. Kamal, speaking about the landscape in Sri Lanka right now when it comes to trauma care. Could you give us a little bit of an overview about how exactly it's proceeding in Sri Lanka?
Yes. Trauma is a global disease, it's a global problem, and when it comes to the Sri Lankan perspective, from 1995 the major admissions to the hospital is trauma, related to trauma and the injuries. And if you think about the figure to understand everybody, 1 in 6 admissions in the emergency point of view is trauma. And if you take about the deaths, 1 in 9 deaths related to trauma in Sri Lanka. And even now, about 7 deaths due to trauma and accidents happens in Sri Lanka. So, in the present health system, we take care of these trauma patients. When they injure, they will bring to the primary care hospitals, and we have an ambulance system we established, that is 1990. So, but number of ambulances are not very enough to cover the whole island. So, there are a lot of ambulances in the primary care hospital though. So, in future we can link all these ambulances to bring them to the hospital. So, that is the primary care. And when they come to the hospitals at the primary level, we'll have to make them stable. And after that, there are mainly the two designators like level 1 trauma centers, Colombo and Kandy. For the major surgeries, we'll have to transfer them to this major hospital for advanced trauma care. So that is how we practice at this moment. But it's not the mature trauma system. So in a trauma system, there are few elements: prevention, and then the pre-hospital care. So when they come to the hospital, there should be initial trauma care, and then there should be a transfer protocol to the advanced trauma care. So we run this at the present normal health system. So probably it should collaborate with the international level, and we'll have to think about how to improve our system in future to improve the care of these trauma patients.
All right, Doctor. Well, I believe that is a good introduction into our discussion, because I can directly direct the final bit of your statement to Dr. Professor. Now, well, when it comes to the international standard, I believe there's a little bit of a gap when it comes to Sri Lanka's local standards and international standards. Being from Singapore, could you please give us a little bit of an insight into what the trauma care system looks like in Singapore?
I think it's just like what Dr. Kamal had mentioned, a lot of us tend to think of trauma as an accident which has occurred, which is not preventable, and there's nothing much you can do about it. But I think the approach that we've taken in Singapore is that to treat trauma as a disease which can be prevented, which needs good treatment and good rehabilitation to bring a person back to where they were so that they can continue living their lives, achieving their dreams. And I think the whole system is focused in on that. So what we did in Singapore, and although we're an island, we're a small island, we divided the country into 3 different areas. The Ministry of Health set up a National Trauma Committee, and within each of these clusters, there are hospitals, which are major trauma centers, which coordinates care for that entire region. This includes not only the neighboring hospitals, but even our primary healthcare facilities and engaging with our pre-hospital services. Our pre-hospital services are also centralized, and they provide very direct upfront treatment to the patients very quickly and bring them back to the hospitals itself. But I think this is just one part of it. I think the other major part of the trauma system in Singapore is preventing accidents, looking at the data of all the accidents which have occurred over the years, looking at it and trying to draw out conclusions as to how to prevent it. And also focusing on making our patients return back and reach their full potential after the event is over. So I think that's how a mature trauma system kind of develops, by the focus not just being on the initial treatment and the rescue of the life, but preventing accidents in the first place and bringing them back to where they were. So Singapore's trauma system has been evolving in that setting. There's still a lot more we can do. I think although our mortality rates have come down quite significantly over the last 1 decade with a very concerted approach, there's always room to improve. And every life you save is a whole lifetime ahead of you, especially because trauma usually affects the very young. And it's a whole life of productivity and whole life of dreams and growth, and which they could have achieved if not been cut short for trauma.
Definitely, that just highlights the importance of trauma care being an integral part of the hospital system in itself. Now, Doctor, once again, I come back to you. We just heard about the system employed in Singapore. Now, there's a little bit of a curiosity after getting the basics. Prevention is a very key area as well. When it comes to our national hospital, now National University Hospital of Singapore has such specific approaches. What does it look like in Sri Lanka?
Yes, prevention of trauma. So it's an integral attempt that we have to make with the doctors and the Ministry of Health and the other parts also. So in Sri Lanka, the police and the forces will help us to sort of prevent in trauma. Especially there are programs conducted by the College of Surgeons, the education programs. So we will have to concentrate the elderly population. So usually they are at home. So road traffic accident is superior to only home accidents. It's mainly the elderly population. So how to take care of them to, rather than going for a disastrous trauma situation by fall. And then the children. So we'll have to keep them away from the disasters and the dangerous things by the parents. So I think in Sri Lanka there was a huge population admitted with burns earlier. So now that burns issue is no more in Sri Lanka, very remote areas only. So another thing is the school children. So even the teachers should be included these prevention programs. So those programs conducted by the College of Surgeons for the community. And then road rules, and those are very strictly should implement, and for that we need the support from the police and the relevant authorities. So if we sort of allocate the funds to prevent the injuries, it's an invention, because we can save a lot of money in future. So when you think about a patient admitted with trauma, to take care of them, and then rehabilitation and back to the society will take a huge amount of money rather than prevention. So preventive measures is a good invention for the country. So we are doing a certain education programs, but there are a lot to improve.
I see. Well, there is room for improvement in every aspect, of course. But just to follow up on that, do you believe we have been having steady growth in the prevention aspects more so than previous years?
It's into both sides, because even though we developed some preventive measures, the pattern of trauma over the years is different. Now, if you compare about many years before, we don't have motorcycles and the vehicles. Now, with the open economy, there are a lot of motorcycles and vehicles. So, it increases the road traffic accidents. So, we'll have to change the preventive measures towards that special kind of trauma. And during the wartime, we got a lot of gunshot injuries. Now, there is no gunshot injuries. So, it depends. But we do continuous educating programs to the College of Surgeons. Then now, trauma secretariat is actually started many years before. Now it strengthens this year, and we are having this National Trauma Conference this year. So collaboration between the Ministry and the College of Surgeons will improve the prevention part also.
Right, so there's a lot of collaborative work that has to be undertaken, multiple sectors of the health field in order to make this happen. Yes. Well, we have spoken about prevention quite a bit. I feel like we should move into the next step that you mentioned in your initial response, Doctor, about pre-hospital care. Now, could you please explain to us, Professor, what is pre-hospital care and how does it look like in Singapore?
So pre-hospital care is probably one of the most essential parts of trauma care, because when you have a patient who's got in an accident and they are bleeding, blood is time. The more you bleed, the worse off you are. And stopping the bleeding and getting the patient to a hospital is the most important aspect here. And this is where the pre-hospital services come in. Beyond responding, their initial response of bandaging, applying tourniquets, making a good assessment of the injuries, conveying that information back to the hospital so that they can prepare, and bringing the patient expediently back is really crucial. On top of that, in Singapore, for example, we do something known as diversion. And this is also a feature of many mature trauma systems, where we say, okay, we want to get the patient at the right time to the right hospital, which means that we will designate a few hospitals in a region as a major trauma center, and we will push as many patients as we can to that center, because that center basically can look after these patients very quickly, expediently, and get them to the operating theaters where we can stop the bleeding as fast as possible. So the pre-hospital services focus on that, on making that quick assessment, stopping bleeding, bringing them over to the hospitals, and conveying that information in a very expedient manner. So many different countries have different systems that allow this. In Singapore, we have a centralized pre-hospital system, one single number to call for both the fire department and the medical ambulances, and that's a coordinated response to reach, so that an ambulance can reach every patient within about 10 minutes across the island. Granted, we are a much smaller island, so the challenges for Sri Lanka, of course, will be much greater because of the great distance. So because of our small size, we're able to achieve very quick response from that system. But at the same vein, having a pre-hospital system only works well if there's a lot of integration with hospitals. So what we do is we have lots of training sessions together with the paramedics, with our pre-hospital services, to share cases, to share with the paramedics what happens after the case comes to the hospital, and we have a mutual learning from each other so that we grow together. And I think that's a really important part of the collaboration between the pre-hospital services as well as the acute care hospitals, which are looking after the patients.
Right, so there is a lot of, it's a lot of interconnected issues when it comes to the pre-hospital care as well. Now, that leaves room for curiosity when it comes to Sri Lanka's situation right now. Doctor, please enlighten us. What does pre-hospital care look like in Sri Lanka at the moment?
Yes, what my friend Professor Raj said is the interconnected system. So we have some element of that system. So we have ambulances, and there is a national number. But number of ambulances is about 390, if I'm correct. So to cover the whole island, that is not enough. So we'll have to increase the number of ambulances. So there is a proposal to use the parked ambulances in the primary care hospital. So if we interconnect those all ambulances to the 1990, When the free ambulance are there, rather than sending an ambulance which is parked many kilometers away, we can reach the patient very soon. And then, as he said, that right patient to the right place at right time. So in Sri Lankan transport and road system and the traffic, and Singapore is a small country and we'll have to think about our island. So it takes many hours to transfer to major trauma centers sometimes. So we have to have the control of initial trauma management at the primary level. But the advantage of Sri Lanka is it's only 4.5 kilometers distance to a doctor in Sri Lankan population. This figure advertised and published by the WHO many years before. I think now it's more or less. But still, when they reach, now in initial trauma care, as he said, the bleeding, and then there are two more things, that whether he is breathing and whether his airway is patent. And to take care of that, basic doctors are trained. So to bring them to at least to that closer hospital with the ambulance, if we can cover within a reasonable hours to bring our patients, that is our aim of doing it. But at this moment, we have our ambulance service and we do it. So sometimes we can't bring it to a major trauma center in Sri Lankan point of view, but we can bring it to a level 3 or 4 center, and before bringing, if ambulance crew, paramedics are trained, then they can do primary initial trauma care to a certain level, to making the airway patent, or they know how to stop bleeding. So that is our aim of doing it in future. At this moment, we need acutely, if you combine this, all the ambulance to the national service, with the economic crisis and all, it's not easy to bring another 500 ambulances. But there are about 700 ambulances. It's scattered over the island in the hospitals, so we can use them.
Right, I see. Well, Professor, before we go into a break, can you please just give us a little bit of an estimate? I'm pretty sure our audience would like to know, when it comes to the integration of the pre-hospital care management system, do you believe that it would take quite a lot of time? Do you think it can be expedited?
Integration of this is with the available manpower and with the available technology is not a big thing, I believe. So if the IT experts can now, if you take an example, the Uber, so the taxi, they use the app, so that is easily we can do that. There will be a cost, but I think it's not difficult if you come to a discussion and if you come to an agreement to sort of interconnect those things. As he said, this should be a central controlling place for this paramedics, pre-hospital care. We have it. I'm not saying we don't have, but probably the Ministry of Health, collaboration with College of Surgeons, we have some discussions to improve it in future.
Right. Well, there's much to look forward to as well when it comes to the development of the pre-hospital care system as well as the health system in general in Sri Lanka. But before we get into any of the specifics regarding trauma care, let's go in for a short commercial break. You're watching Special Report. Be right back. Welcome back. You are watching a special report on the trauma care in Sri Lanka. Now, we just had a very insightful first segment regarding prevention and the pre-hospital aspects of trauma care and the basics of trauma care and how it compares in comparison to international standards. Now, Professor, I believe we just had a discussion about what comes before the actual trauma care. So now, could you please explain to us, Professor, about basic trauma care? Now, what happens when you get to the hospital? Could you please give us a little bit of a breakdown?
Thanks, it's a great question, and really this is where most of us as surgeons and as trauma surgeons, this is where we get the most amount of, this is one of the most challenging periods when the patient first comes in for both the surgeons, the emergency department, as well as our nurses when we first receive this patient. I think what's important to note is that from the point of a patient's arrival, how quickly we get this patient to a place where we can stop his bleeding is the key metric that we need to look at. So when a patient first comes in, we will rapidly try to focus on what we call the ABCs. There's the airway, his breathing, his circulation, assessing quickly his injuries, performing all the immediate interventions that we need to stabilize and save his life, and then very quickly have an assessment of where is he bleeding from, what are the different injuries that he has. It could be in the brain, it could be in the chest, it could be in the abdomen, in his limbs, or it could be a combination of all of it. And then putting that all together very quickly and getting the patient to the operating theatre or to the intensive care unit so that we can quickly stop bleeding. And we try to achieve all of this within an hour. Even the faster we do it, the better it is for the patient, which means that this requires a lot of coordinated teamwork. There has to be leadership by the key trauma team leaders, as well as good collaboration with everyone else who's working with them. Information transfer between people and between different areas of the hospital has to be quick. And it's really a whole of hospital effort when everyone rushes down, puts in maximum effort to quickly get this patient to the next stage where they need to be. Like we said earlier, time is life in trauma, and moving the patient through the system as quickly as possible makes the huge benefits provides huge benefits to them later on for the rest of their hospital stay as well. So that's a brief summary of what happens when the patient first comes in. This is where also you will have different groups of doctors and nurses all working together, from the emergency physicians to the anesthesiologists to the surgeons to and various groups of surgeons all coming in together in order to try to save a life.
I see. Well, considering the fact that there is a lot of communication that goes on, especially for the initial trauma care, compared to now, of course, Singapore has a little bit of a geographical advantage as well. It's very easily reachable and also very interconnected in comparison to our larger landmass. In respect of those aspects, Doctor, how does our initial trauma care system fare?
Yes, it depends on where the patient comes in Sri Lanka, because always we can't bring them to a what is called level 1 trauma center. So if you think the National Hospital or Kandy, there is an accident service. So all the setup what he elaborated, most of the elements are well established, and we are giving the advanced trauma care, advanced life support. But when we think the peripheral hospitals, the general surgeons, when we say that general surgeons, all surgical patients are being managed by the general surgeons, and they have to take care of the trauma patients in those peripheral hospitals, because without doing the initial care we can't send them to the main hospitals, then they will die on the way. So we'll have to do the basic things. So in Sri Lanka there is a well organized initial resuscitation rooms, or say that trauma resuscitation bay, or primary care unit, or emergency care units. In all the hospitals we have that setup, and there are of course the lack of staff, lack of manpower, lack of instruments, those are there, but the system has already developed. So for that moment, even when the patient comes, they take care of basically the airway, breathing and circulation, and make them stable. So if you think about advanced imaging methods like X-ray, scan, CT scans, in some hospitals we don't have those facilities, but still with the clinical assessment they manage the patient, whether to go to the theatre, as he said, whether to send to the ICU, whether to keep for under observation, or whether this patient should go to a higher trauma level center safely. So if we have to go for the theatre, we will take care of that by the general surgeon. So initial trauma care is differs which hospital is reached. So actually we have the decision and plan to get even the level 4. Level 4 means they don't have a surgeon, but they take care of the initial trauma management, that airway and breathing and circulation. Those places need some infrastructure, some equipments. So in future we are going to provide them as well because it's the time it matters. So we don't have time to transfer to the ideal place. So this initial trauma care should expand up to the level of level 4 and to the certain level, as we discussed, the pre-hospital also. So it's a little bit different compared to Singapore. All hospitals are not in the same level, but we have the basic approach and basic initial trauma care unit in each hospital.
And especially when it comes to remote hospitals as well, there's an added disadvantage and an added obstacle when it comes to time as well, and time and equipment basically. Could you tell us a little bit, Doctor, if we have seen a progressive increase in the equipment brought into remote trauma centers, if we have seen a proper development in the healthcare infrastructure?
Yes, we can see that because when we were trainees in peripheral hospitals, it's very less advanced. Actually, there is what is called adjuncts in the first assessment, like X-rays and ultrasound scan. Most of the primary care centers now, ultrasound scan machine is now provided, and that is a significant improvement. And blood bank service, because always like that we stop the bleeding, we have to refill the lost. So emergency blood is available most of the centers nowadays. So when we think about over the years, it improves, but the problem is the volume of trauma also increase. So then the outcome will have to increase more, and we'll have to increase the capacity of absorbing these trauma patients, so we'll have to expand more. But when we compare to the past years, we are improving. But there is a say in trauma management, we can't send the patient for imaging. Imaging should come to the patient. So that means there should be mobile X-rays and mobile ultrasound scan. So most of the centers now we are developing it. So probably, so this collaboration between the Ministry of Health through the Trauma Secretariat and the advisory body of this trauma management is College of Surgeons. So that collaboration will bring us a good results in future.
Right, so we can look forward to many new things as well when it comes to trauma management. Now, I think we might have had to take this topic up before we took in actual practical application of trauma care at all, and that is trauma care education. Now, that is a crucial aspect. That is the foundation of having a good trauma care system, I believe. Professor, could you please explain to us in Singapore, what does trauma care education look like? What does the initial introduction to trauma care look like?
So I think it's a very important question when you're looking at a system as a whole. And it starts not just from the medical providers themselves. It starts at home. Trauma education starts at home. It starts at the workplace, it starts at the community centers, and it starts in the schools. Simple messages about what do you do if you see someone bleeding, how to apply pressure over a wound to stop it from bleeding, when to call for help. If an elderly person has fallen down, how to help them without injuring them more. And in the workplaces, especially in the factories and industries, how to maintain safety, how do you respond if, let's say, something fell on someone's head or crushed someone's arm, how do you respond? Education starts there. So the things we can do, and this is the responsibility of the trauma system now, to go down to these individual areas and share. It's not the role of a single person, it's the role of the whole system, ranging all the ways from the doctors, the nurses, the administrators, the volunteers, going down to different levels. And this is where the whole community comes in. That's the beginning stage. Within the medical community, I think training goes by first making sure everyone's equipped with a basic set of skills. And this is where, for example, the concept of advanced trauma life support as a course which is propagated across the world, which has really changed the way we manage trauma. And certainly Dr. Kamal's efforts in Sri Lanka with the National Trauma Management course has really amplified that within Sri Lanka, and is very heartening to see. I think the last part of education is a bit of a reflection, looking back at what we have done, what we have achieved, and trying to figure out how to do better. And to do this, we need to be able to measure what has occurred so far. This is where we develop things like trauma registries, where every trauma case is logged in, reviewed, and over the span of years and months, we're able to pull up key lessons as to tell us this is where we could have done better, and we feed back to our system. And this is where, again, the hospitals, the pre-hospital services have to run educational sessions together to educate both from both sides of the spectrum on how we can do better for our patients. So really, education is a great question because it underpins everything about a major trauma system, and it starts right at home and really finishes when the patient goes back to the community.
Right, so that is basically a cornerstone of having a well-developed trauma response nationwide. Well, I believe, Professor, you mentioned about the ATS, the trauma, the
NTMC.
Director for the National Trauma Management Course. That's what you are, Doctor. Now, that is a new initiative. Well, not new, but it has been in the works for quite a while. And really, I believe it's something that has probably saved countless lives. As a professor would have mentioned, a very heartening effort. Could you please give us a little bit more information onto this initiative?
Yes, National Trauma Management course established in Sri Lanka in 2009. We have trained over 3,000 doctors up to now. We are running the 63rd course in next month. So that is for the doctors. But when you think about trauma training, I believe what he said, that it should start from the home, school. So we address that part through the College of Surgeons in certain education things and to the community. Now we had it for the teachers and the military and the police about a couple of months before, and last month also we had a program for them. But when it comes to the doctors, that is my I'm the director of National Trauma Management course, but it's a teamwork as we discussed. So the whole team should train how to manage the patient when the patient arrives. We can't do it single-handed, so we'll have to train the nurses. So there is a special course designed for the nurses, that is initial trauma care for nurses. It's run by the College of Surgeons. And there is a team trauma training course. For that, all the team will come and will simulate the trauma patients and will train them. That is another education part of that. And then when it comes to basically the doctors, now when the patient comes, the consultants are not there at the receiving bay. That's for the doctors we train, and postgraduate trainees also we make compulsory this course, that is NTMC. So that is the basic trauma management. So the surgeons also to be trained for the advanced trauma care. So we have what is called decision making in major trauma, that's run under the College of Surgeons. So we do the dissection in cadavers, and we train the doctors, surgeons, how to tackle when the patient comes, because we can't train it in normally in humans. So we use the cadavers and train it. And then there is an advanced cadaveric course that is called ASSET. This Kotalawala Defence University brought it into Sri Lanka. So we have that course also. So it's a range of training, from the team trauma training, nurses training, and then doctors, and the advanced trauma care for the surgeons. Because now when it comes to the peripheral, those are not designated trauma centers, but those are the places patients will come. So surgeon is there, anesthetist is there. So then we'll have to do the trauma surgery also. They are not named as trauma surgeons. All general surgeons should have the skills of managing this critical trauma. Before the definitive care, we do what is called damage control surgery. Means we stop the bleeding and stop contamination, means spilling of stools from bowel and all those things. That to be done in the level 2 and 3, and then only we have to transfer for the advanced trauma care centers. So we have a good training part under the College of Surgeons.
We have a good foundation, and we're going to have to build upon that as well. Well, before we discuss any of the additional details when it comes to trauma care, let's take a very short commercial break. You're watching a special report. welcome back. We are in our final segment for the special report. We're in conversation with Professor Menon, trauma and vascular surgeon, head trauma service in National University Hospital of Singapore, as well as the vice chairman of the Asian Collaboration for Trauma, and Dr. Kamal Jayasuriya, who is the director for the National Trauma Management Course, national delegate of the ISS, the ACT executive committee member, and the Sri Lanka representative of the ACT as well. Now, we have come into one of our most momentous segments, especially when considering the actual focus of this program, which is the advancement of trauma care in Sri Lanka. But before we get into the actual collaborative efforts that have been made in, I believe it's important for us to touch on just one more subject regarding the technicalities of trauma care, and that is about mass casualty events. Now, we've seen multiple mass casualty events as well, so I believe it's important that our audience has a bit of an insight into it as well. So, Professor, could you give us a little bit of an insight into what happens in such an unfortunate event?
Thank you for the question. A mass casualty event is defined as an event which that would overwhelm the hospital system. But how we plan and prepare for that event makes all the difference. And you know, the most important people in trauma are the people, but the next most important thing is the plan. And this is where mass casualty events really put it to the test. In a mass casualty event, if you can envision, let's say, a building collapse or a blast or some major road traffic collision where there's a flood of patients coming in, there's a lot of coordination again that has to be done between different agencies, both at the pre-hospital level, the police, the ministries, and the hospitals, basically to coordinate the flow of patients quickly through the system. And this is a period of time when you potentially could be overwhelmed, and automatically backup plans have to kick in about what are the new ways of delivering care to these patients quickly to move them through the system. Because any hold up now is going to cost lives and is going to cause a lot more difficulty for the next patient which needs to come in. So most countries have multiple exercises and plans in order to do this. In Singapore, every few years, every hospital has 300 patients simulated flooding in through the emergency departments in order to stress test the system to make sure that we can cope with it in the unfortunate time when this happens. And I think that's a really important part about building up a trauma system, being prepared for this eventuality as well. And in Sri Lanka as well, they are, in fact, even today, I think an exercise ongoing to test some of these efforts as well, which is very commendable.
Right. Well, I feel like that's a perfect segue for me to move back into you. Doctor, now we just spoke about mass casualties. Could you please let us know, apparently there's a stress test being run at the moment as well. Could you tell us about the environment? Have we fostered proper management for mass casualty events?
Yes, Anuradha, as you know that we have faced a lot of mass casualties in the past and even recently also. So bombing, multiple bombing and gunshot injuries and earth sliding, tsunami, and all those we have controlled in an accepted manner with the available facilities. So as he said, if you fail to prepare, we have prepared to fail. So we will have to prepare, that is called preparedness. So disaster management preparedness plans are there in our hospital, even in peripheral hospital. If I take an example, in Dambulla base hospital, we have a very good preparedness plan. So I must thank the military groups. Now even today they do this drill, they mollage the crowd to come as the mass casualty, and they are like exact patients. So in Sri Lanka we have these facilities to do the preparedness. And how the message transferred now, not like in a developed country. Now we have these difficulties of sending the message, say that if it's a work hour it's easy, but off work hours we have given the target to the operator, telephone operator gives only 3 calls. All others should call other 3, and other 3 will call others. So it's very short time they will inform, and the manpower will absorb very soon. So we are in lacking of sometimes equipments. So when the alarm rings, they will bring the equipments, take the equipments and come to the site. That is how we plan that. It's a small hospital, Dambulla, but we get a lot of trauma. So like that we have the preparedness plan under the supervision of disaster management group. So there are trainees they will appoint to the hospitals, and they have to do as a program the setting of this emergency mass casualty plan. So it is being done, but I hope that it should be done as a national manner to each hospital. We have to make it compulsory, and hope that the trauma secretariat and the College of Surgeons are focusing on this. Because of the past history of a lot of disasters, we have designed it and we are doing it, but we have to do for the all hospitals because we don't know which part it will happen, like last time.
Right. There is a lot for us to anticipate as well, and having a uniform system across the island would be essential and would potentially be the final goal as well when it comes to trauma care. Now, Professor, I would like to ask you this question. Now, we've been speaking about the two nations separately, an international and a local standard. But of course, collaboration is something that will help to boost either one of the standards to a significant level. So could you tell us a little bit, Professor, about collaboration efforts and how it could be essential for countries like Sri Lanka and of course nations like Singapore to collaborate with other nations and to actually exchange information and improve their systems?
Thank you. There's indeed, as you mentioned, a very strong network of trauma surgeons across the globe. We all recognize that we have the same duty to mankind, which is basically to save people whose lives should not have been cut short by an accident. And this has brought the community very close together. In Asia, we have the Asian Collaboration of Trauma, which is a grouping of the various trauma societies across Asia to share experiences, thoughts, and resources as well. This starts off from having teaching sessions where we share cases and experiences, having programs where doctors who have finished their basic training can come over to other countries to basically learn. And this goes both ways. From Singapore, for example, our load of trauma, fortunately, is low. But it also means then, by visiting our neighboring countries, we can learn so much from the surgeons. And for example, the capability of the Sri Lankan surgeon in managing trauma is immense, with their wealth of experience that they have. And there's much that we can learn from our neighboring countries as well. Now, I think some of the other ways that we can help, perhaps, is in the role of in the area of research. In Singapore, we do collect data quite aggressively about each trauma case that comes in, and that forming a registry. And sometimes having registries across multiple countries helps us analyze the data of trauma incidents across the region and help to share learning points and best practices in terms of how we can better help each other. And this is where we look forward to further development in our relationship between Singapore and Sri Lanka to mutually benefit each other in improving trauma care, not just for the youth, not just for the doctors, but also for the future as well. And we hope to continue those efforts through common platforms like this, and we look forward to further collaboration.
Right. Of course, collaboration, I believe, is one of the biggest factors for change and exponential growth as well. Doctor, please, could you let us know about the collaboration efforts that are currently underway? And could you tell us exactly how these collaboration efforts could actually improve, or maybe we could be sharing information to other nations, just like Professor mentioned. Maybe we could be gaining information. It's a wealth of knowledge, of course. Could you explain to us how exponentially advantageous is a collaborative effort between nations for trauma care?
Thank you very much for the question bringing to me also. So, relationship between Singapore and mine is a very long relationship. Actually, I would say that this is my second home, because we visited many times to Singapore in point of this trauma. I have done my fellowship also there. And they trained 13 surgeons to Sri Lanka. So, they trained the trauma nurses. And when they need, before bringing the ATLS here, to train our doctors and the surgeons, they help. So this is an example that collaboration and sharing of the experience and the resources. So I must stress the fact that analysis of the data and research and auditing of this data is very poor with us, because we don't have a proper trauma registry at this moment. We collect the data, but it's in the different parts of the hospitals, regions, and we have what is called injury surveillance program also. So for over many years, what I have seen, to collect data and analysis, it can't be the responsibility of the nurses and the doctors. So it is not going to practical in Sri Lanka because our doctors are very busy. So they are not concerning about recording all these things. Even though we press and push, it's not going to get success of collecting of data. So it should be a national-wide program in future. So College of Surgeons and Trauma Secretariat will think about this aspect in future, I hope. So that is one aspect that we can share. Another thing is, there are many doctors and surgeons interested in trauma. But you know, this trauma, it's an emergency. We have to take a challenge. We don't have time to think and analyze it. Quick decision making should be there. So it's a challenging profession. So when they come to this, that is because they are really interesting. So these surgeons, doctors who are interested in trauma should have a collaboration in the country first. So we have a lot of elements. So College of Surgeons is the home, and then College of Anesthesiology. Without anesthetists, we can't do surgery. And College of Emergency Physicians, Disaster Management College, and all these should be collaborate. And we have to work as a professions to advisory board as to the Trauma Secretariat. And then we'll have to think about Asia. So I'm a representative of Asian Collaboration for Trauma, and he is the vice chair. Next year he will be the president. So we can share a lot of things in Asian perspective. And College of Surgeons signed the Memorandum of Understanding with the International Society of Surgeons. So that is in the global level. And the main chapter of that is IATSIC, International Association for Emergency and Trauma Care. So under that, we are running the NTMC as the basic course here. So there is avenues that we have opened for the future doctors, young doctors. So they should keep these connections and these collaborations with them. So probably Singapore is the well-developed trauma system is having in the close country. So they can advise us. They can bring their knowledge. And as he said, there is a lot of volume of trauma here compared to them. So they can learn from us. So each other, we have to make it into a system and give a better care for the patients.
Right. Well, I believe that was a very insightful discussion regarding the trauma care in Sri Lanka and trauma care across the globe. Now, before we end off, Doctor, I would like to ask you, is there any sort of message that you would like to relay to our public or to our government or even to our local resources regarding trauma care and the advancement of trauma care in Sri Lanka? Is there any message that you'd like to leave?
Thank you. Thank you for the last question, or whatever it is, very important question. So as a member of the College of Surgeons and in the trauma team and the director of NTMC, what I have seen over the years, we need the collaboration between the Ministry of Health, government, and the personnel in the Ministry of Health giving the trauma care. So if you have that good collaboration, actually we can win this war. I would say it's a war. Right? So hope that signs are very good. Now Trauma Secretariat is now very active, and College of Surgeons, College of Anesthesiology, and other specialties helping and collaborating for trauma care should get together and discuss about the principles. First thing, we have to think about the trauma registry. So if you start that, from that onwards we can increase our trauma care. Another thing is, as I said, in the peripheral hospitals, we'll have to see whether there is any infrastructure difficulties or equipment. If they don't have the equipment, even though there is an MBBS doctor, they can't do this airway breathing and circulation. So we'll have to have a quick survey immediately if Ministry of Health and government can supported these things, it improves within very short time. Then the initial figure that I told you in developing countries or low and middle income countries is 6 times the death of severe injuries. We can minimize that.
Right. So there is a lot more to be desired, but there is a lot more hope when it comes to the development of this sector as well. Unfortunately, that is all the time we have in this discussion tonight. Thank you very much, Professor Raj Menon, from the Trauma and Vascular Surgeon, Head Trauma Service in the National University Hospital of Singapore, and also the Vice Chairman of the Asian Collaboration for Trauma. Thank you very much, sir, for taking the time out of your schedule to speak to our audience and to explain to us exactly how vital trauma care is to the healthcare system. And of course, Dr. Kamal Jayasuriya, thank you very much for taking the time to come and explain to our local audience exactly what our local perspective and our local climate is for trauma care as well. I believe our audience would have taken quite a lot of information back with them after this discussion is concluded. Well, that is all the time and discussion that we have for you tonight. If you had missed any of today's programs, you can always rewatch by catching us on our YouTube channel, youtube.com/Derana English. I'm Anuradha Vikramasinghe. Thank you for watching. Have a great night.